ideas. What you consume influences who you become. On the Mind and Matter podcast, we learn together from the best scientists and thinkers alive today about how your mind-body reacts to what you feed it. Before starting Mind and Matter, I spent 10 years in academia doing scientific research. I got a PhD in neuroscience where I focused on neuroendocrinology and the neurobiology of behavior, and before that, I specialized in molecular, developmental, and evolutionary genetics. I use my scientific background to help parse and translate the information that guests share on the podcast. In addition to the podcast, I write long-form written content inspired by the show where I integrate what I've learned across episodes. I also have a free weekly newsletter where I provide you with upcoming guests, share links, and provide commentary on scientific studies and research that I'm reading, and more. Visit mindandmatter.substack.com to find all of my content. This episode is ad-free, and I rely on my audience to support my efforts. If you're getting value from this content, please consider becoming a paid subscriber to the Mind and Matter Substack. For just $5 a month, you'll get early access to episodes and other content, full episode transcripts, and I'll prioritize answering your questions in emails and the comments sections. You can also support me by checking out the links in the episode description to my affiliate partners who make various health and wellness products that I use and enjoy myself. You'll receive a discount and help support the podcast that way. And if you want the benefits of a paid subscription, but it's not in your budget, simply sign up for my free weekly newsletter, send me an email, and I'll give you a complimentary paid subscription. Word of mouth is the best way to help the podcast grow. So if you like what I'm doing, please share your favorite episodes with family and friends. The purpose of the podcast is to provide you with information obtained largely from primary sources, the people doing the research and producing new knowledge. This content is never meant to serve as medical advice. And with that, enjoy the episode.
Beautiful, sunny Palo Alto, California, Stanford University. I'm an anesthesiologist, at least a day a week. I see patients, and the rest of my time is spent doing research into non-ordinary states of consciousness, including anesthesia, and psychedelics is a major focus of my lab. We do human and animal studies trying to understand how they work.
Okay, so you put people under. You're in the operating room putting them to sleep.
And then waking them up. That's the most important part, actually.
Yeah. I mean, speaking of sleep, how is or isn't anesthesia like sleep? Is it very similar, or is it a distinct brain state completely?
It is. If you want to piss off a bunch of sleep specialists, you can tell them that this anesthetic is just like chemical sleep. That's they don't like that, and they're right. That there are some similarities, and as you go through, there's depth to anesthesia. As you might imagine, it's not a straight line necessarily, but as you get deeper, as the doses of anesthetic go up, you pass through some sleep-like stages on your way down, and of course on your way back up. But where we get to for surgery, as you might imagine, is a state of unarousability, where you have no memory formation, no conscious awareness that we know of, immobility, and hypnosis. So that's a much, much deeper state of consciousness, and the EEG looks radically different from what you would see during normal sleep.
I see. And so how does it compare just at a high level, the EEG signature?
So it's much simpler. So what's interesting about sleep, and there's a lot to say about this, but sleep, sleep has an architecture, right? Yeah. Sleep is ancient. It's in every species that we know of, and you cycle through different stages. And when you put someone into anesthetized state, which we do regularly, millions of times across the country every day, maybe not millions, but what you see is a much more organized rhythm, and it's a really simple rhythm. Like the standard, we actually have monitors that are built for monitoring depth of anesthesia using EEG, and what they're targeting, the good numbers are describe a pattern that when I talk to residents and teach, basically explain it like this: if a 5-year-old kid could draw it, the patient is surgically anesthetized, and that's because it's so simple and loopy, and there isn't a whole lot of spatial complexity in the signal. And that's sort of one way of thinking of what's going on in the brain. The soup is being kept warm by these thalamocortical rhythms, but there isn't a whole lot of information being processed, and there isn't a lot of informational content in that EEG.
Mm-hmm.
The more, as you get to lighter stages of anesthesia and eventually wakefulness, all of that sensory information, the chaotic noise of the smelly, tasty, touchy world, all of that comes in, and that actually that complexity is reflected in the complexity of the EEG. And that rhythms are much more complicated rhythms, much finer detail, and so it's a simplistic way of thinking about it, but actually anesthetic EEG is simple at its base, and that's how you know that you're doing your job in keeping the patient under.
I see. So, I mean, roughly speaking, if from a naive standpoint, if you don't know anything about anesthesia, but you do know the basics of sleep architecture, you've got non-REM sleep, stage 1, 2, 3, 4, you've got REM sleep. Non-REM sleep is when you've got these large slow waves that you see in the EEG signature. Are you seeing large slow waves akin to that in anesthesia, even if they're not the same frequency, or is it completely different?
No, you still have those large slow waves, but you don't a typical a typical thing that you see during sleep. And there's another rhythm. It's called an alpha rhythm, and this will come up again. That is very prominent during general anesthesia, and not so much during normal sleep. So this is something that happens when you close your eyes. You can see a prominent alpha rhythm in your occipital cortex, which is where vision is processed. So you can kind of make that link between eyes closed, and suddenly there's no external sensory input, so it kind of defaults to this rhythm. During general anesthesia, like anywhere you look in the brain is going to have that strong alpha rhythm. That's not something that you typically see during NREM.
I see. And so obviously, people are unresponsive during anesthesia. And if they're in deep anesthesia, we presume that there's no conscious awareness at all. And then there's this component of amnesia. My understanding is that when people come out of anesthesia, depending on the anesthetic, depending on the depth, there's going to be some time that they can't remember even after they start to come out of it, or when memory formation is impaired. Thinking about conscious awareness versus memory formation and impairment, how do we know? I mean, is it possible that there is some level of basic awareness even in deep anesthesia? It's just that memories can't form of it, and so people don't report it?
Yeah, that's sort of a terrifying philosophical concept of like, what if you did experience everything during anesthesia, you just couldn't remember it?
Mm-hmm.
And you sort of, it's like there's a Black Mirror aspect of that. And I think conceptually, like you can't know that for sure. What we do know is the incidence of awareness under general anesthesia, which is about 1 in 1,000. And it doesn't seem to be something that you can prevent by monitoring EEG. So to say that we know why it happens is actually not clear either, which is a little disturbing, but it is very rare. And when I say awareness, I'm talking about anything like, sight, sounds, not necessarily pain and like feeling like you're getting cut into, which, would honestly be terrifying. That's extraordinarily rare, where you have like full awareness of sensory perception under anesthesia. But yeah, so is it like back when anesthesia was being developed and these concepts were being worked out, people actually drew a distinction. So we stopped using the word pain, right? So there's to talk about a patient who's anesthetized. Is the patient in pain? Sounds like a reasonable question when you're getting, a scalpel put to you. But technically, pain is a conscious process, right? And these patients are unconscious. They have no recollection of it. They still can have a physiological response, tearing, heart rate elevation. But if you wake them up afterwards, they'll have no recollection. They'll obviously may still be in pain, but they won't have recall of the actual traumatic event. The other thing that happened with the language is that we started using this term nociception, right? Which is the idea that signals can get through, but they don't integrate. They don't integrate into conscious awareness. And you can see that actually in a number of ways. So one of the things, so I do anesthesia for neurological surgery. So things like aneurysm, cerebrovascular aneurysm repair, a number of other things, tumors. And one of the things that we do is we monitor cortical function. We want to make sure the patients aren't having a stroke, but they're not impinging on something important. And we do something called somatosensory evoked potentials, meaning you just stimulate a nerve like your tibial nerve or radial nerve, and you can get a mixed sensory motor response. And you can actually track that impulse as it goes all the way up, and you can eventually see it in your cortex. So you can see that the signal is clearly getting through. There's a sensory signal that's traveling from the periphery to the center. You can see it with visual evoked potentials. If you flash a light, you'll see things going off in the occipital cortex, even under anesthesia. Brainstem, auditory evoked potentials. All these things are actually routine things that we do to monitor the integrity of the nervous system, which means that information is getting through. What's not happening is that mysterious process of integrating it into conscious awareness. And that is still very much, that's just kind of the edge of science right now, is understanding how that happens and what that consists of.
So basically, I think it sounds like we understand, we take in information from our sensory organs. We know that information goes up to our sensory areas of our brain. And then it goes elsewhere in the brain. It gets combined and integrated, and stuff happens to it. It's processed before it comes into our conscious awareness. And we sort of know at that level that happens. We don't actually know what that integration process looks like exactly.
We can get some clues, and I'll point to work at University of Michigan that I like in particular, looking at EEG and anesthetic states. George Mashore is one of my favorite researchers over there, and former head of their department. But you can look at cortical organization, right? So how does information move locally and globally during anesthesia? And that you see a lot of a change basically in the architecture of these cortical modules. So you can see a lot less, again, complexity and local correlations in activity that seem to relate to depth of anesthesia. So again, it's this idea that you're disrupting these local and long range interactions, and that's probably related. Those kinds of interactions, that's probably what integration consists of. And the thing that we call consciousness is, I would say, very likely to be the result of all of those those interconnected pieces of your cortex talking to each other in real time.
Yeah, I mean, it makes intuitive sense because, very, very roughly speaking, right? Like we have a sense of touch, we have we have our eyeballs, we have our ears, we have all these different streams of information, but we don't consciously perceive all of these things separately. We have this one unified scene from moment to moment. So in some sense, all of these different channels have to be literally integrated together somehow so that we have that unified perception.
Yeah, that's that is the mystery. There's a lot of this is actually one of the reasons why I stopped studying consciousness very early on. It's because it seemed like one of those not insolvable, but almost like philosophical questions that you could come to any number of conclusions that are essentially not testable or very difficult to test. And there's been a lot of, I guess, progress in the field of consciousness studies over the last 20 years that now I think we're starting to get somewhere. But very early on, I realized that the way that I like to think about these problems and kind of attack them is more of like an engineering point of view, that maybe I'm not going to understand how the system works, but can I at least move it predictably by doing stuff at it. So drugs, electricity, the non-ordinary states of consciousness, how can you put these things together in a predictable way to get an outcome, whether that outcome be a particular state of consciousness, dreaming, or a mental health outcome, or a transformational experience. And that is some of the most exciting things that I've seen going on, in kind of the mental health revolution that I think, in the midst of right now.
So there's probably, I would imagine, a large number of anesthetics. There's certainly multiple to choose from. Can you give us a sense for how, as an anesthesiologist, you choose what anesthetic to use for a given application?
The one that I know for 100% certainty is going to get into the patient, no mistakes there. And the one that makes people not want to throw up afterwards. And that actually limits our choices to a very, my favorite anesthetic is a combination anesthetic. So it's sevoflurane, which is a gas that you breathe in. One of honestly, the coolest things about anesthesia, people say we don't really know how anesthesia works. And that's like true. We don't really know how anything works. But one thing we do know is that things like sevoflurane, isoflurane, ether, these are all kind of related molecules, work across just shockingly well across the entire animal kingdom. Down to even plants. You can anesthetize a plant,
What?
which is kind of messed up. And it's, that raises a whole, different set of, philosophical issues, I guess. But the point is, it's a very old and deep process. These are molecules that are related to things that archaebacteria were probably secreting into their environment to silence the local competition. They're not really complex molecules. So that's my first stop is the gas, sevoflurane. You breathe it in, you breathe it out. I know it's getting in, and it's extremely effective. And the dose is very predictable from patient to patient. Now there are problems with it, in that people can sometimes wake up a little bit delirious. It takes a while to wash out. And one of the least fun aspects of surgery and anesthesia is the nausea afterwards, which I've experienced it. I've seen it. It's not something that I particularly look forward to. So the other drug that we add is a drug called propofol, made famous, unfortunately, by Michael Jackson, but it's been around for, I'd say, about 30 years now. It is extremely safe, and it's one of the most widely used drugs in anesthesia. It doesn't cause nausea. It's hypnotic. It doesn't really treat pain. You need a different group of drugs for that, but it's a hypnotic agent that causes loss of consciousness very reliably. And the thing that I like about it is it comes on and it comes off very quickly. So older anesthetics, the problems were, it would interfere with your heart rate, your blood pressure, it would cause liver, kidney issues. It would take forever to wash out. This is really what modern anesthesia has done very well, is turn anesthesia from something that is frankly scary. In the 80s, there was a 2020, if you remember that show, I think it's still on, a show where they said something like one in 500 patients won't wake up from anesthesia, which is like a scary, crazy thing. That, honestly, I don't think the numbers were quite that high, but it was dangerous. In the intervening 30, 40 years, a lot of changes have happened to make anesthesia I think the safest specialty in medicine, in that, now we can monitor patients who are unconscious with, great precision. There's a really good safety record. The drugs have improved. Anyway, that's not, this actually relates to something I think we're going to talk about later, which is that because of these improvements in safety, because now we operate on sicker patients, because we can now, anesthetize parts of your body and keep your brain intact, that's opened a lot of doors in terms of the variety of anesthetic states that we see on a regular basis, and have led to some very surprising observations that I think we'll talk about a bit, like in particular dreaming and related phenomena.
So whether it's propofol, whether it's some of these gases that you mentioned, what are the mechanisms of action here? Do they have very distinct mechanisms of action between these drugs, or are they similar to one another?
So they're different, and there's other classes of drugs like dexmedetomidine, for example, that have very specific targets. In that case, an alpha-2 adrenoreceptor, which basically suppresses all of your sympathetic outflow and really puts you. That's as close as we get to like chemical sleep, I think, is dexmedetomidine. But these other drugs, propofol, sevoflurane, they're pretty dirty. In fact, as a general theme, my experience in psychopharmacology has been that the dirtier drugs are the more effective drugs. Ketamine is another example. So it can be used for general anesthesia. It is fantastically profligate in the number of receptors that it seems to hit.
Yeah, and just for listeners, that's what you mean by dirty. They interact with many different receptors.
Yes, sorry, it's not a clean drug is one that we think of as has a very simple, clear mechanism of action. It binds at one receptor. Sevoflurane, for example, isoflurane will bind their binding sites at GABA receptors, ion channels, voltage gated calcium channels, presynaptic release machinery. Like there's all kinds of ways in which it slows down neurotransmission and may lead to the unconscious state. The GABA receptor is really, that is the main inhibitory receptor, or the main receptor for the inhibitory neurotransmitter GABA in the brain. So what we're doing is we're basically turning up the inhibition in your brain with drug like propofol or sevoflurane. Phenobarbital falls in that same category. Until you basically suppress all activity and your brain goes quiet and you stop forming memories, stop perceiving anything outside of you.
So by their very nature, right, they're having a profound effect on consciousness. So and apparently these are dirty drugs so they have many parts and little widgets in the brain that they interact with. Do they have any lasting effects? Do they have any effects beyond the anesthesia itself? So, for example, do people who come out of surgery ever report mood changes or improvements in symptoms for something else unrelated to the surgery, or changes in personality or anything like that?
They sure do, and it's not consistent. That to me is still one of the enduring mysteries, is that people, you talk to any anesthesiologist or even anyone really in medicine who deals with patients who've had surgery, and I guarantee you that everyone will have a story about someone who woke up different, better or worse. And both, we've heard both. Like there's something called pump head, which is what people said Bill Clinton had after his open heart surgery. There's a pump that you use to recirculate your blood while your heart stopped. That can cause some, maybe some neurological issues. I'm not going to speculate, but and people attribute that alternately to the pump in cardiac surgery or the anesthesia. People will sometimes tell me like, I wasn't right for a year. Like I couldn't hold a thought together. And, there's, when you start looking at this in really big numbers, it is very hard to really pin it down to anesthesia. So, so we're talking really about the downsides of anesthesia. That when you look at patients who are, for example, at high risk for having cognitive decline, where you would be worried about, what's going to happen to my grandmother, when she undergoes anesthesia. Is it going to precipitate some sort of further cognitive decline? And this is work from UCSF, but what is amazing to me is really, if you look at the trajectory of these patients over time, why are they having surgery now? Why did someone fall and break their hip, right? There's overall a pattern that, folks are on the down slope. Mm-hmm. And of course, there's the acute trauma of surgery and anesthesia. But what happens is once they recover from that acute trauma, they're basically rejoining a line that was on the way down. So it's very difficult to untangle what exactly happened. So that's one type of lasting effect that we hear a lot about in anesthesia. And you hear the same thing at the other extreme of age in kids. Is anesthesia going to cause a cognitive issue in my child, right as they're developing? There's a lot of, my brief time in pediatric anesthesia, that was a lot of what the discussions with parents were like. And again, you have to ask this question, why is a child having surgery less than 2 years old. Like typically there's other comorbid issues that might also affect their cognitive development. So pinning it on the anesthetic is not really that easy. And when you look again at thousands and thousands of patients and try and match them with controls, it is very difficult to pull out an effect of a single anesthetic. Sometimes with multiple anesthetics, there's a little bit of a signal, like the development of attention deficit disorder later in life, a couple IQ points. To be honest, if I had to choose between having a hernia repaired and a couple IQ points, I want the hernia repaired, and I could play sports and whatever. These are small persisting effects if they're real. Now there's a flip side, which is something I'm just as, if not more, interested in, is personality changes and transformations. Once we started, so a lot of the work that I do is really the intersection of mental health and anesthesia. I work closely with psychiatrists. We're looking at drugs like ketamine that have been repurposed from anesthesia to psychiatry for depression. We're looking at other, anesthesia-related non-ordinary states of consciousness and how they might we can leverage them for therapy. But as we started doing this work, I started getting emails from patients from all over the country. And some of the stories they're hard to get out of my head, but it's very hard to come up with a systematic explanation for it. This one woman told me that, again, not expecting anything, she's just coming in for a carpal tunnel release. This is a minor surgery to have on a morning and be home for dinner, for lunch even. And she had just years and years of this voice on her shoulder, this kind of a compulsive thoughts, and just this this devil on her shoulder that just made her depressed and generally miserable. She wasn't diagnosed with schizophrenia or anything, but it was some mix of obsessive compulsive disorder and depression and anxiety. And after this carpal tunnel release, this like trivial surgery, she doesn't remember anything about the surgery, but what she remembers is the voice is gone. Like how on earth does that happen? And so when you start looking for these, like, you'll find lots of stories, but not a lot of consistency.
I see. So it's not like all the patients with bipolar disorder who got propofol woke up and they felt better. There's no clear patterns like that.
I don't know how many anesthesiologists are going to listen to this show. If any of them are, we have got to stop doing propofol versus sevoflurane for X. Like, trying to find differences between these anesthetics for any condition is almost like, other than nausea, is like, honestly, I think a fool's errand at this point. It is, there seems to be very little relationship between the specific anesthetic used at this point in, anesthesia history, and any of these outcomes. Even things like depression, which is something that I'm very interested in. Most of the data that we have, hundreds, maybe thousands of patients at this point across trials, the dominant effect is that patients are doing worse. They're not improving, in terms of mental health. So there's a lot of interest in repurposing anesthetics to treat mental health disorders like Xenon. That's the most exciting new one. That has been used. I think Boris Yeltsin had a Xenon anesthetic, the most expensive, cardiac surgery in the world at that point. But the point is that some of these drugs are being repurposed for their purported mental health benefits. But when you look in surgical patients and surgery and anesthesia, that's not what you see. What you see is a big stress event. If we know, specifically in terms of mental health and really general health, your body doesn't do well after severe trauma. There's increased risk of heart attacks, strokes, lung injury, kidney injury, liver injury, cognitive, or potential cognitive issues, delirium. Why would we think depression or mental health would get better after that? And that's typically what we see when we look at large numbers of patients. Now, that doesn't really address the question of, can we somehow look at anesthetic agents and use them in a particular way to get a better mental health outcome? But that's a different, I think we'll get there, but it's a different sort of question than I'm going to give you this drug and it's going to do this to your brain and your brain's going to get better and you're not there for it, but you'll be cured. That is very elusive, and I don't know that we found that magical recipe yet.
So one drug that at least has been used for anesthesia in humans, still is in animals, I think more often, is ketamine. And people have been talking about ketamine for all sorts of reasons, but let's just start with ketamine as an anesthetic. Can you give us a little bit of the history there and talk about the applications ketamine has as an anesthetic? When do you use it versus other drugs? How is it working? What doses and those things?
So ketamine's been around for a while, about 60 years ago, I think it was. It's been in clinical use for about for 50 years in the United States, and it was developed for that. It was developed as a better version of PCP, things that for anesthesia, the things that uh, anesthesiologists in the 50s and 60s liked about PCP was that patients would not react to surgery, and they would keep breathing, right? So the mainstay of anesthesia before that is drugs like ether, opioids, all of which would, at the same time as they suppress sensorium, they also suppress your respiratory drive. And in the absence of a way to monitor your oxygenation, which we didn't have in the 1960, that was deadly. So it was really important to find anesthetic agents that wouldn't suppress your respiratory drive, your cardiac output. So PCP actually had a lot of those features in its favor. What people didn't like about it was the emergence delirium. I don't know. That wasn't coined for PCP, but it was well known that people emerging from PCP anesthesia would have really delusions, delirium, a lot of agitation. It was kind of I would imagine not a lot of fun to deal with. So ketamine was better. Ketamine had less of that. It had all of these beneficial features.
And it was engineered. People synthesized this. They were trying to make a better anesthetic.
Yeah, that's exactly what happened. Edward Domino at also the University of Michigan. He just died, I think, a couple years ago at a ripe old age. Ketamine, actually, he called it ketamine, but it just sounds weird to me. So anyway, so ketamine was initially developed as an improvement on PCP, as a surgical anesthetic. The story was, at least from some of the pioneers at Stanford, that surgeons thought they could get rid of anesthesiologists because, hey, the patient's breathing. We don't need you guys anymore. And so they would do just ketamine anesthesia. And what became very obvious very quickly is that if ketamine's the only drug you're going to use, it's not going to go that well. Patients still have a lot of these issues with wake up, and there's something that I would not call it a joke, but it's sort of a wisdom, nurses' wisdom in the recovery area after anesthesia. When a patient is not, there, oh, did he get ketamine? Like that's still the impression, even though that, statistically it doesn't increase the likelihood of delirium after surgery. There's still this general sense that patients aren't quite right for a while when you give them high doses of ketamine. So ketamine's kind of happily moving along in the 70s and 80s, and it's finding its place in anesthesia. It typically is an adjunct, meaning it's ketamine and something else. Ketamine was also an analgesic, right? So it treats pain. That was something that was also recognized very early on in the late 70s. And one of the other main uses today for ketamine outside of anesthesia is pain management. So patients with chronic pain syndromes, they will come into ketamine clinics for infusions. Our hospital, Stanford Hospital, still will admit patients for 5-day infusions of ketamine for refractory complex pain syndromes. These are typically lower doses than what you would use in psychiatry. But my point is, right, so the big picture is we went from an anesthetic to an analgesic in the 80s and 90s that was increasingly appreciated. People started realizing that if you give ketamine, you need less opioid. So it was called, in our textbooks, it's called an opioid-sparing analgesic. And that's an interesting some interesting further developments that maybe we'll talk about later. But ketamine does interact with the opioid system. It can reverse opioid tolerance. These things are all like great in the context of surgery and trying to treat pain in the operative theater. So this is all kind of humming along, and then in 2000 there was a landmark study from Yale where they were, I think, looking at ketamine in a very different way. They were interested in mimicking psychotic symptoms in schizophrenia, because ketamine, again, like the weird dissociative state that it puts people into, reminded. This is a group led by John Crystal. They gave a low dose of ketamine slowly. Did I wink out there for a minute?
Barely. So you can just keep going.
Anyway, they gave a low dose of ketamine with the idea to minimize those psychotomimetic symptoms, and so they spread it out over 40 minutes, that infusion. And what they found was patients felt that, like, their depression. These are depressed patients they looked at, and after a single infusion, patients would say, "I feel like I haven't felt in very long time." I actually don't know what they said because I'm just looking at the graphs, but I know what patients have said to me after ketamine infusions. So they would get this rapid relief from depressive symptoms, and it would last for about a week. A single infusion, even though it's cleared from your blood, is still exerting effects out to a week. And since that paper 24 years ago, I guess, there's been a steady growth, and now recently an explosion in the use of ketamine for mental health disorders. And it's gone beyond depression. It's being tested for PTSD, alcohol use disorder, any number of things. That's kind of the bird's eye. That's more than a bird's eye view.
Yeah. So, a number of things to talk about. So one question I have about anesthetics generally, but we can also use ketamine. We can also focus on ketamine because it is becoming more widely used. There's ketamine. I see ketamine clinics all over now. So there's people going in for, I guess, weekly or even more frequent infusions. Other than the effects on the brain, is there any negative consequences to taking ketamine regularly? Does it upset your liver or your kidneys or any other organs in the body or anything like that?
Well, unfortunately, yeah. So ketamine has a reputation. Ketamine is on the World Health Organization list of essential medicines. That should tell you something. It's up there with like antibiotics and a couple other things that I don't remember. And effective. It's a battlefield anesthetic. It's an analgesic. But that safety is really based on single dose use, as in use in an operation in the field for dealing with acute trauma. We know a lot less about long-term safety of ketamine use. What we do know already is a lot of it is actually literature from China. So China, again, there isn't a lot of public knowledge about this. They don't really publish epidemiology of their substance use disorder profile. But there is a lot of murmurs coming out of China over the last 15 years about raging ketamine abuse epidemic. A lot.
Really?
Actually in 2015, China lobbied the WHO to put ketamine in Schedule 1, the most restrictive, no medical use category, to basically halt international traffic of ketamine. Why on earth would they do that with one of the WHO essential medicines? My best guess, and I think was borne out with a lot of writing from that time, is that they had a very serious problem with ketamine abuse. It's cheap, it's easy to make, and what shows up in the literature. This is a little bit of the sociology of science. Is why is it that what papers out of China about ketamine are all about neurocognitive dysfunction after long-term heavy ketamine use?
Ooh.
Like, that should be a tell. I didn't know that was an issue. Like, where are you finding these patients who are using so much ketamine? So you couldn't write that paper, 10 years ago in the US because it just wasn't that, you could actually, if you, went to enough raves, but it wasn't like a widespread public health issue. So So we do know something about ketamine toxicity with prolonged heavy use. Neurocognitive issues, neurotoxicity. Again, we're talking really high dose heavy use, and oftentimes we don't know what else these folks were taking.
Mhm.
Bladder issues are a known thing. So there's something called interstitial cystitis, and it typically doesn't occur with a few infusions, and it's actually pretty rare. I mean, we're under 1%, but I don't have exact numbers. And this is a type of inflammation in your bladder that it's not an infection. It's like, and it may be sort of like an autoimmune type thing. It's incredibly painful. It is very difficult to reverse. And it can lead to things like requiring a bladder replacement, which is like a major quality of life issue. So again, not common, but these are the sorts of things that you wouldn't know unless you had done epidemiological studies of large patients over long periods of time exposed to varying doses. It doesn't seem to be associated with high doses in particular, just repeat dosing. There's, liver issues that, again, rare. These things are generally rare. And when I talk about risk, I don't want to come off as, alarmist or anything. Like every drug has risk. This should not be a surprise. Any treatment is potent, period. By definition, if it's potent, it also carries risk somewhere. So it's a matter of balancing, if you don't know about the risks, you can't mitigate them. Right. So you want to balance the potential good that a drug can do against the potential harm. So these are the main, it's really like bladder, like some brain stuff, and rarely liver issues surface with heavy ketamine, prolonged heavy ketamine use.
And so ketamine's effects are highly dose dependent. So at high enough doses, it's anesthetic. And then based on what I know that's out there, right, you've got the low dose application, which is all the studies being done, ketamine for acute depression treatment. And then I guess you would say the medium doses are probably what you see with recreational use. Is that accurate? And can you give us a sense for like how big this dose range is and where you start to draw the line between the anesthetic effects versus the dissociative effects versus the antidepressant effects?
So there's been a lot of work trying to link this is like a tension right now, the ketamine field, like the biomedical model, where we're trying to minimize these psychiatric, like the experience of the drug, versus a school that you can call CAP, ketamine-assisted psychotherapy, where that altered state is actually key to the process of transformation. And I would not say at this point that there's a clear winner here. There's evidence on both sides. But so the doses, it really, really runs the gamut. There are patients who will say that they benefit from very low dose ketamine. Most studies will show that you need doses in the range that will produce effects, as in like the patient can feel it. They'll dissociate, they'll get that floaty feeling, they'll get a little disoriented maybe. They'll get some perspective shifts. That's really the antidepressant dose ketamine and what you'll get in a lot of ketamine clinics. In community ketamine clinics for depression, that's the starting point, and the doses just go up from there. So you can really have patients. They're not typically like giving, with extreme exception, I'm hoping most of these clinics are not giving large anesthetic dose ketamine. What the mail order ketamine doses are like, that's oral ketamine, sublingual ketamine. Those are trip doses, right? So you're getting effect. This would be on par with how we would use it in the operating room as an adjunct. So they're not anesthetic doses. I want to be clear. We use it typically as an adjunct to other anesthetics. But it's the same general dose ranges. And you will find patients who, you get tolerant to ketamine, then you have to dose escalate but typically the range is 0.5 milligram per kilogram to 1 or 1.5 milligram per kilogram for patients who are experienced in psychiatric clinics.
And so you mentioned that a lot of these anesthetics, including ketamine, I think, are dirty drugs in the sense that they have lots of different mechanisms in the brain that they interact with. So we know that at least the most famous mechanism that ketamine is known for in the brain is antagonizing the NMDA receptor. Two questions I want to ask here. One, to what extent do we know like that is the mechanism or a key mechanism for its therapeutic effects or its anesthetic effects? And then two would be, what are some of the other mechanisms of action that ketamine has that maybe we don't hear about as much?
So the NMDA receptor hypothesis has been around really since the inception of, it's been around since ketamine was really appreciated as a treatment in psychiatry. Is the NMDA receptor the thing that makes ketamine an antidepressant? If it is, then you would predict that other drugs that target the NMDA receptor would also be antidepressant, and they would be rapid antidepressants. What has panned out, and it's been a long time since we found out about ketamine, is a graveyard of failed NMDA receptor antagonists for depression. There's trial after trial, lots of different mechanisms, different specificities. And, you can can quibble about details, but by and large, like if that was the magic of ketamine, why can't we do the same trick twice? So that suggests that, maybe there's something else going on. So one of the other, well known from the beginning, and, I hinted at this before, ketamine is also an analgesic. It interacts with the opioid system. It can reverse opioid tolerance. How actually it does that is still a little bit controversial, but there's been this strain of thought that, ketamine abuse liability and ketamine's analgesic effects may be linked to the opioid receptor somehow. So I'll give Alan Chatsberg credit for this, a former chair of psychiatry here at Stanford. He was under the impression that, people are, I'm going to paraphrase him, just getting high. That's really what's going on with ketamine. And it's not, and all that's happening is that this is a euphoriant, and it's, that it's an opioid-like effect. And I don't agree with him on that. And I didn't to begin with, and I don't in the interpretation. But one thing he was right about, which is he predicted that if ketamine works through opioid receptors, you should be able to give someone an opioid receptor blocker and then block the antidepressant effect of ketamine. I actually thought that was totally not going to work in 2016 when we started talking about it. But we did the trial. Again, this is empirically testable. I think this is a great example. And there were are still very, very few examples where you do that kind of testing in mental health, testing mechanism. So what do we do? So this is a study that was led by Nolan Williams and myself, and supervised by Alan. We got patients with treatment-resistant depression, and we had them. It was a crossover trial, meaning they would come in, they would get their first ketamine infusion, either with naltrexone, the opioid blocker, or not. And then once they recovered back to baseline, which typically took about a week or two, because ketamine doesn't last forever, they would come back and they would be crossed over to the other treatment group. So if you were a patient in the study, the first time you might get ketamine and do great, and then you would come back for the next one. And we would generally expect that when ketamine works once, it'll work again. The next time, though, you get naltrexone before you get ketamine. And what we found on average was that naltrexone completely blocked the antidepressant effect of ketamine.
Wow. So that would mean that ketamine has this acute antidepressant effect in people with depression. If you give this opioid receptor blocker and then give the ketamine, presumably the NMDA receptor is still being antagonized, but something is now different in terms of what is going on through the opioid system. You're blocking some opioid receptors, and you're saying that gets rid of the antidepressant effect.
That's what we saw. It was a small study, to be fair, 12 patients. So I think I look forward. I am confident that there is a replication study in the works from the UK. Mm-hmm. So I think it will actually hold up. But yeah, that's basically what we found. Does that mean the NMDA receptor isn't involved? It does not mean that. It just means that, well, there's also another system involved, not a surprise. And again, when there are a lot of interpretations, right? Mm-hmm. This doesn't mean that ketamine acts directly to opioid receptors. There is some evidence for that. It could mean that ketamine releases endogenous opioids like endorphin and kephalin. That's something that ketamine can do. It's also possible, and this is something we didn't really take that seriously at the time, but I've come to rethink, is what if naltrexone, what if opioids are involved in a totally other process that you need to, or another part of your physiology that just needs to be in place in order to get a ketamine effect? And what I'm hinting at is placebo. One of the things that naltrexone is known for, and naloxone, a related drug, is that you can block placebo effects. You can block the effect of expectancy with opioid antagonists. This is
and which opioid receptor are these blocking?
They're not selective for mu or kappa, but all of the imaging evidence and the evidence to date indicates that it's the mu opioid receptor that it's working through. That there is a placebo. This is very well understood for placebo analgesia and a little bit less well understood for placebo antidepressant responses. But they work through the mu opioid receptor, and they are very likely generated by the release of endogenous opioids, like in kephalin.
Yeah. So ketamine's potentially interacting with opioid-based mechanisms in the brain that may underlie placebo effects themselves. And then, of course, we've got this issue that we can also talk about, which is how you do placebo-controlled studies for psychoactives like this. And so it sounds like it's going to get pretty complicated here.
It gets pretty complicated. One way of looking at this data is that ketamine is all placebo, that people are walking in with an expectation that, like, hey, I'm in this cool trial and I'm going to get better. And we do this horrible thing by blocking the expectation benefit with naltrexone. And then, surprise, there's no effect of ketamine. So one way to look at that is like, honestly, Occam's razor is that, well, there is no ketamine specific effect, that it's placebo.
Yeah. I guess the first thing that jumps to my mind there is just animal studies.
Well, animal studies, I mean, show me a depressed mouse.
Yeah. Okay.
So I do this work, so I'm very, I'm sensitive to the criticism, but that's one of the issues. That is honestly, when you look at, digress a little bit, but like, why have pharma drugs left CNS, like central nervous system, mental health therapeutics over the last 15, 20 years? It's because like there's really nothing comes out of these animal studies for a while. Like when I was an undergraduate, every week I would see like, we cured depression again in a mouse, substance P or NMDA or whatever. And these drugs would fail, and they would fail using these very specific behavioral tests in mice and rats.
Yeah. I mean, I eventually wanted to talk with someone about this on the podcast. It didn't occur to me that it might come up with you today, but well, I mean, what's your general view on our ability to model things like depression and anxiety in rodents, and how much stock we should put into that work when we're thinking about clinical applications in humans?
Yeah. So as I said, I'm less a philosopher than an empiricist, in that if the models worked, we'd have found some new drugs by now.
Yeah.
Our 8th generation SSRIs. So some things do seem to work. Some models do seem to work better than others. So drug abuse, like that's like something that's consistent across, across species, even, fruit flies. And we've worked out, the dopamine system, like it seems like that is pretty consistent, and you can model a lot of that self-administration behavior in animals like mice and rats. Depression is difficult, and again, you have to, it ties into things that are honestly objectively hard to measure. So with substance use disorder, you can look at objective outcomes like, are you compulsively seeking and using a substance? Have you sold all of your possessions? Is your life, are you basically ignoring your friends and family? Are you using escalating doses? Are you tolerant? Like those are things that they are actually objectively measurable. Depression is a little bit, trickier. And I'm not a psychiatrist, so I want to leave it to your next guest to handle that of like, how do we diagnose depression? Is it one disease? And I'll just point folks to Leanne Williams, also at Stanford, had a wonderful study this last week, where they subtype depression based on imaging markers, into 6 different categories. So each which may be sensitive to different drugs. Anyway, the point is we don't do nearly a good a job as that um, in in depression with mice, with subtyping, being able to predict drug effects. And right, there's been a big push to change how we approach modeling, period. So starting about 15 years ago, there was a big push at the National Institute of Mental Health to stop using these like learned helplessness models where you put a mouse into, a cup of water and see how long he struggles, and that's like hopelessness. Where like, yeah, you have him upside down and see how long the tail suspension test. I hate that thing. So it's moved more to looking at dimensions of disease. So, for example, depression. It's not, depression has a lot of symptoms. One of the symptoms is change sensitivity to reward, anhedonia, where rewards just aren't as rewarding anymore. Sleep. That's another domain that you could model. It's the effect of stress on all of these things. So we're getting better at not trying to anthropomorphize mice quite so much.
Yeah, and just do better, more granular phenotyping of these very broad terms that we apply.
Yeah, and to me, the big challenge and what lies ahead is building bridges. Now that we're starting to understand the physiology and like the biomarkers that underlie these component processes, then trying to find, how does that show up in a human, right? It's not necessarily going to be the same way. And we see that again and again where things that look like they should work based on, what does a stressed human look like? Like, and this mouse looks like it's stressed. Why doesn't it respond to psychedelics the way I think it should? That basically speaks to the difficulty in understanding like how do behaviors actually translate and whether they translate at all. Does the physiology, can you find the same types of physiological processes happening in mice, rats, non-human primates, and humans? And there's a lot of there's a lot of yes there and a lot of I don't know.
So with regard to ketamine's addiction liability, how does that look? Because on the one hand, there's animal research. I've talked to Christian Lucier, for example, on the podcast, and he's done head-to-head comparisons of cocaine and ketamine in rodents and shown pretty clearly that it's certainly much less addictive than cocaine when you do the head-to-head comparison. But on the other hand, clearly there is some abuse liability because you mentioned the China thing earlier, and there are clearly, I've seen people who have a problem with ketamine, so it's clearly addictive to some degree. How addictive is it, and do we really have a handle on that even?
So it's not as addictive as cocaine or alcohol or opioids. I think it would be a mistake to say that. It's also, probably on par with, how addictive is MDMA. It's not as addictive as methamphetamine, but it's certainly people will abuse it. And the issue is you take something that has mild to moderate abuse liability and just talk to people or wander on Reddit, you will get all the evidence you need that, people can very quickly move from taking it in a therapeutic setting to just using it on their own and developing a problem. The issue is, all right, it's not everyone. It's going to be a segment, maybe 10%, maybe less. But the more you expose people to it, right, with limited regulation, where now, 1% of a million is actually quite a lot of people, right? That's 10,000 people. Now, how many people have depression in the United States? I don't know. Estimates are up to 50 million. And is that your, if they're all eligible to receive, mail order ketamine, you can do the math. That's like a lot of people with a new substance use disorder that they didn't necessarily have before. And again, these numbers are, what is the actual percent of patients who go on? I don't think we have good information on that yet because we're just at the beginning of mass exposure to ketamine in the United States, really spurred on by what I think is irresponsible marketing through telehealth providers.
for ketamine, for psychedelics, for all the drugs that, everyone's really excited about right now that are psychedelics or related psychoactive compounds, there's this question of to what extent are the subjective effects that people consciously experience actually necessary or important for their therapeutic effects. So as we mentioned, as I've covered on the podcast before, ketamine's being studied pretty intensively right now because it has these acute antidepressant effects. I know that you've done at least one study where you basically combined ketamine with anesthesia so that people obviously weren't aware of the effects when they took the ketamine. Can you set up that study for us and just describe what the motivation was and what the basic results were?
Sure. So, the drug versus the trip, that is one of the most interesting and compelling and impactful questions because it really dictates where do we go when we try and develop this and scale it up. And just point to folks like David Olson, Brian Roth, who are developing non-hallucinogenic psychedelic analogues, which is a great empirical test of this question. Drugs that have very similar biochemical effect to classical psychedelics, but don't trigger that the experience. Those studies are underway. They have not been they've not been tested in a formal clinical trial for a mental health condition in humans, as far as I know. So we don't know the answer to whether taking the trip out of the drug works. So being an anesthesiologist, I saw a very clear solution, another alternative solution to answering the same question. Is we have patients with depression all the time coming in for major surgery, hips, knees, hernias, things like that. And we could set up a test. We could basically eliminate the conscious awareness associated and really the dissociative effect, the trip, by giving ketamine, the same psychiatric dose that's used in countless studies, while they're under general anesthesia. And to be clear, they're getting a different general anesthetic. It's not a ketamine anesthetic. It's where we started. Propofol, sevoflurane is most of the patients in our study. So we tried to set it up as close as we could to a psychiatric ketamine study. We worked with Laura Hack and Alan Chasbury again, who are both actual psychiatrists, to help us get it right. So what we did is we reached out to patients early, and these details are going to be important later on. Patients don't usually hear from surgeons and anesthesiologists about their mental health. So some of these folks are a little surprised. They're like, why are you asking? A lot of folks didn't want to talk about it at all. But anyway, we reached out early. We told them that, we're interested in studying mental health, and we asked them if they want to be a study of a potential therapeutic option that might treat depression during surgery. That was the setup. We took folks who had moderate to severe depression. On average, they'd been for years. These look a lot like patients who were in other ketamine studies that came before. And we track their symptoms using standard scales. And when they show up on the morning of surgery, we would meet them. They would go in for surgery. They would go off to sleep. And we basically waited until they reached a certain depth of anesthesia. So all of our patients were basically at a equivalent depth that's associated with general anesthesia and no recall, right? This is again where we started our conversation. And when they're in that state, we gave them ketamine. We were blind. We were just put in a syringe. We didn't know what it was. The patients were obviously unaware of what we were doing because they were under general anesthesia having surgery. And the anesthesiologist in the room also didn't know what we had given them. So it was a standard dose, again, a single dose. This was really aimed at if you take away the conscious experience and you just have the drug in your system, you still get some sort of antidepressant effect. We're looking at short outcomes, meaning the 1 to 3 days after the infusion. This is when a lot of the earlier single dose studies of ketamine, how they were set up is the peak effects were at those 1 to 3 days after. So what did we find? The ketamine group, the folks that got ketamine, they got better. They got a lot better. 50% response, 30% remission, meaning half of them cut their symptoms in half or more. and a bunch of them no longer met criteria for major depressive disorder for at least a few days. This looks a lot like what ketamine does in other studies. Now, the placebo group also had about 50% response and 30% remission. We could not tell the difference between the groups. Both of them had this enormous treatment effect. And there were patients where, I swear to God, like there were two in particular where I saw them after surgery. And one of them was telling me, like, I could dance. And this was like her fifth surgery for cancer, like not someone who was like, prone to, exuberant outbursts. Like she was like just legitimately like just happy. Like it was infectious. There's something that, people like we know about, in healthcare generally, like sometimes like when you find yourself, a patient's attitude rubbing off on you, like that should tell you something. Like that's how bright this woman was. And I was thinking, my God, like this is working. Like we took the trip out of the drug, and like she's got to be in the ketamine group. Placebo, of course. Another patient where she actually had a pretty rocky postoperative course. But she was, she told us like she's so happy to be in this trial, like she's able to deal with stress in a way that she wasn't before. She's taking exams from her hospital bed. Anyway, these are the stories that I was accumulating as we're doing the study. So why I'm telling you that is these were real transformative experiences. Those are those are words that patients use. I didn't suggest that. And it was shocking to me to find out that like we're getting these effects in the placebo group. And that I think made a lot of people uncomfortable. We got a little bit of hate mail for this study. I wouldn't say hate mail, but it's one way to look at this study is that, well, this shows that ketamine doesn't really work because it's no better than placebo. That is not how I look at the study. And to be honest, you can't really interpret it in that way because there was no third group, where they were awake, for example, and got ketamine.
So how do you interpret it? And then I have basically a question about the study design.
Sure. So the way I interpreted it, we considered a few different possibilities. One, that anesthesia blocked the effect of ketamine, which we think is unlikely because the size of the ketamine effect was so similar to every study we've done before. The other possibility we considered is maybe it's a common factor. Maybe anesthesia itself is an antidepressant. And we talked about that a little bit before. And going back over hundreds and hundreds of patients where mental health is monitored, surgery and anesthesia make depression worse in almost every study. So that seemed very unlikely to explain this. So what we settle on is that it's maybe it's expectation. Maybe, and I hinted at this before, this process of reaching out to patients. Patients feel seen. They feel heard in a way that they usually don't in the run-up to surgery. These are patients who have issues, major life issues that are dragging them down. And on top of it, they have surgery coming up. And that sets in motion a series of expectations. And that made me really think a lot about psychedelic trials and just how heavily selected patients are there, how excited they are to be in such an interesting study, be an elite group of patients. Like I am, it's being part of something.
Right. I mean, I remember when I went to grad school, like when you're applying to grad school and then they invite you to the interviews, you feel so good. You're like, I get to go and I get to be part of the group.
Like I'm on the team. Like,
yeah.
That's real. And we did, I was excited to get every single one of these patients because, it's not easy to get folks who are willing to do a study in this surgery.
Yeah. Do you think this sort of fits with the other results we were talking about earlier with the opioid blocker?
Well, that is the question, because it really, like, the simplest explanation for all of these data, which is, again, there are other interpretations. The simplest one is that either ketamine is working through the placebo system or it is all very much expectation based. And that if these patients didn't know they were getting ketamine and didn't know they were in a study, they might not have had an antidepressant response. There's, I don't think that's actually right. I think it is, we have some data that suggests that it's more complicated than that. But what it does suggest is that there certainly is a similarity between the mechanisms that our brain engages during a strong placebo. And I'm not talking about like take two and call me in the morning, like a real placebo. That's called hope, right?
Mm-hmm.
When you really engender hope in another person, yeah, technically that's placebo effect, but it's not a trivial thing to do, which, you probably know from trying to talk to people who are in a difficult spot. It's not easy to break through to them. So to that extent, that process, that, hope, inducing hope, maybe ketamine is acting through whatever that process. Maybe psychedelics are acting through that process. Maybe they're enhancing it. One of the most intriguing findings in reanalyzing this data is that we looked at patients who were on chronic opioids. Right? These are patients like who come in for surgery. Sometimes you're on opioids for pain. And one of the predictions we would have is that we know that the placebo system is involved with opioid receptors are involved. And when you're on opioids, oftentimes you develop a tolerance to opioid medication. Mm-hmm. That could manifest also as an impaired placebo response, right? And when we looked at the data, again, this is very exploratory, but what we saw is that patients in the placebo group, the ones who were on opioids before they got to surgery, like usually for a couple of months, they actually had like no placebo effect, very little placebo effect. Whereas the ones who were not on opioids, they had a big placebo effect.
And that would imply that, if you're on opioids, you've got tolerance, the receptors have been internalized, there's fewer of them. And if the placebo effect is acting through those receptors, then that's exactly what you'd expect to see.
So intriguing, there's something in it all, it's like it's been in front of us this whole time about ketamine. What does ketamine do? Long before we started getting excited about ketamine for depression, we were using it as an opioid-sparing analgesic. We were using it to reset opioid receptor sensitivity. And when, again, very exploratory analysis, not a lot of patients, but I think it's pretty interesting. When we look at the patients who got ketamine, those who were not on opioids had a nice big effect in our study. Those who were on opioids also had a nice big effect. It's almost as if ketamine reset that opioid desensitization that happens with ongoing opioid therapy and basically reset the placebo response system. Right? So and I'd say animal data kind of points to something, but anyway.
Okay, so this is why earlier in the discussion you said something like ketamine can reverse opioid tolerance. This is what you were talking about.
It reverses opioid receptor tolerance, very well known for analgesia, like opioid, like when you give patients a lot of opioids over the course of a long surgery, eventually the opioids don't work as well, and that's an acute tolerance process. And you can reverse or unwind that process by giving ketamine. A single dose of ketamine oftentimes will, after surgery, when the ketamine is washed out, patients will now be sensitive to opioids. They'll be able to be treated with opioids. So it's, these pieces, it's not dead, certainly not established.
It's not fully formed, but yeah, this is, I didn't know about all this. Yeah.
This is where we're going, at least. And really, the mechanism of placebo, I think, is going to be central to understanding how ketamine and even psychedelics might work. And it really speaks to the importance of experience in a way.
Yeah. So before we get into some other stuff, I have to ask this question because you just triggered me. So ketamine is becoming more popular as a street drug. It has for a number of years now. So it's out in the world. People get it. We're also obviously in the middle of an opioid epidemic. So given what you've told us about how ketamine can reverse opioid tolerance, is there any danger that if people are out in the world mixing even if not at the same time. If you're on opioids or abusing opioids, and then you take ketamine, and then you take the same dose of opioids you were taking yesterday, are there any risks here?
So it's a really good question. I'll be honest, I don't know the answer to it. It has come up a number of times, and when I've looked, I have not found anything very compelling. That's kind of the prediction you would make, that if you have someone who's now starting to use ketamine and they were opioid tolerant,
Mm-hmm.
are they now going to be opioid sensitive and sensitive to all of the effects,
Yeah.
including the respiratory effects? I don't know the answer to that.
Okay. But in theory, that's what you'd expect, right? That someone
It
who
is
has
something
been
you might,
abusing
again,
opioids
like,
would have a higher
not
overdose
all of
potential.
the opioid effects work the same way necessarily. Like the
Got it.
analgesic effects are different from the respiratory depressant effects, like where the opioid receptors are in your brain and brainstem. So, it's not a foregone conclusion that it would work, but it is something that I'm very curious about, and could become an issue.
So, going back to just this general question surrounding psychedelics and related psychoactives, are the subjective effects necessary or important components of the therapeutic benefit? So a dual question here. One, do you have a strong intuition on what you think is likely going to be the outcome there? And two, what is conclusive evidence going to look like, and how soon will we see that, do you think?
Um, to be clear, the last study we did does not say anything about whether subjective effects are necessary. That's another conversation. We ended up really showing more that what non-drug factors like just the structure of the clinical trial does. But my intuition is that the experience is crucial, is central to the therapeutic effect that we're seeing. I think that we'll see what happens with these non-hallucinogenic analogues, but it's going to be difficult to prove something like that. And the problem basically goes like this: is that what are you going to compare it to? What are you going to compare a drug that induces both biochemical effects and experiential changes? What are you going to compare it to when we're not really sure which one, or whether they act together, whether it's basically an uninterruptible whole? So do you compare it to something that also produces a similar experience? Well, but the closest, like, how are you going to recreate the experience of a psychedelic? So we actually have an approach to this, and it's not it doesn't rule out a special role for psychedelics or a special mechanism, but it gets at this question: what if you were to break this apart, right? What if you could reproduce an experience like psychedelics without the use of a psychedelic, right? And here, what I'm kind of coyly hinting at is that something, a powerful internally generated experience, that's something that we see when patients emerge from anesthesia. So, that if we can focus on that and extend that period, prolong that period, patients wake up and say some true, like, we talked about this before, but we're starting to see it more regularly. This is something that we're doing on purpose that really unearths a lot of emotions and a lot of just really dreamlike experiences that really it's hard to ignore the comparison with psychedelics. But let's back up for a minute. What is proof going to look like? So there are a couple ways to get at this. One is, can you separate out the hallucinogenic experience from the receptor? So there are some theories out there, specifically for psilocybin, that the therapeutic effect is mediated through a different receptor than the hallucinogenic. The serotonin 2A receptor is responsible for the hallucinogenic effect. I think we're reasonably sure about that. But the therapeutic effect might be mediated through a different receptor. For example, the serotonin 1A receptor. Mm-hmm. So you could do a study where you block the 1A receptor, blocking the therapeutic effect, still get the experience. Patients have every reason to believe they're going to get better, but you can judge that outcome. So that is, if that's true. If it's not true,
instead of trying to engineer out the hallucinations, you block the therapeutic mechanism that is independent of the hallucinations while they still have them.
And we actually did that with our ketamine naltrexone study, and that patients all dissociated just fine when we gave them naltrexone. We didn't ask what they thought they got, which is our oversight in 2018, but that's a study you can do. There are other I think really interesting study designs where you basically test the prediction that these biochemical effects, dendritic spine growth, neuroplasticity, these are processes that you can actually interrupt, probably without interrupting the psychoactive effect of a psychedelic. Those trials are a little further down the line, but that's one way that you can get at this, is basically retaining the psychedelic effect, but removing what we think is the biochemical effect. Now, my prediction is that, those two things are never really going to be far apart from each other. That if you think about this in another context, right, these are transformational experiences.
Yes.
I can think in my own life of transformational experiences, and, having bar mitzvah, having a child. Sometimes you hear about, old, angry asshole, guys having heart attacks, near-death experiences, and then changing their personality and realizing they don't, need to be so hard charging. Maybe they should be vegan. Maybe they should talk to their children some more, right? Like, those are transformational experiences. And like, does it really even make sense to say, like, what receptor does the transformational experience operate?
Right.
Like, it's complicated. It's not just like one.
Well, yeah. When I have these discussions, what I always like to bring up is, well, okay, let's think about why people get major depression. People don't walk down the sidewalk and, one NMDA receptor comes loose in the right synapse. They have a set of experiences over a period of time, and that induces the state we want to treat.
I think, without getting too philosophical, a little bit philosophical, I feel like this is a vestige of the success of, so many other areas of biomedicine where, the shining single molecule, single receptor, like, look, we have like cured some forms of cancer. That is a revolution, truly. And it is a result of this kind of, targeted engineering and focus on, single molecules and highly engineered drugs. I don't think it's going to work that way for mental health. And as you said, it's, how do you, if we think about depression really as like maybe a normal response to extreme stress, first of all, is that a disease? And second, how are you going to unwind that without, right? Like, the most complicated drug I could imagine is, the sound of my voice, the touch of my hand, and, the relationship that we build over time, right? Like, that's what drugs in a sense are like approximating, is pieces of that, of pieces of experience. So why not use the whole thing? Why not, why try and put it in a box this way with, just really, this over compartmentalization. So I think experience has a central role in this, and the big picture really is that coming up with evidence for that is not straightforward. I can think of some ways to do it, but that redirects the pharmaceutical industrial complex a little bit, right? If we had clear evidence that there's nothing intrinsically special about the serotonin 2A receptor, that it's a means to an end, and that end is a transformative experience. Well, if we had convincing evidence that were true, then wouldn't we redirect resources away from developing targeted 2A ligands that tickle the receptor in just the right way, and maybe move them towards how do you contain how do you manage a transformative experience? How do you induce it in a reproducible, somewhat safe way? I mean, this sounds crazy with medicine the way it is, that we're going to try and engender a transformative, chaotic experience, which is, what trips often are made of. And that's going to be the unit of therapy. But, talk to psychotherapists. That's a lot of times what they're, trying to dredge up in the process of psychotherapy. Max Wolf, I think, has a lot of interesting things to say. That if you ever get a chance to talk to him, I think he'd be fun. Um, but that's so to I don't even know what question I'm answering at this point, but I think experience matters. But what is going to matter in order to get the kind of development we need and to get this incorporated into medicine is to find a way. You can't give everyone a near-death experience. You can't administer one bar mitzvah as needed. Like, but what you can do, I mean, you can give people a psychedelic, right? But it's the focus now becomes different. It becomes like not so much like the drug itself, but in how do you, who's appropriate? What kind of patients are appropriate? Like this is around psychology. This is not my strength, but
Mhm.
and then how do you make that experience special, meaningful, and impactful?
Yeah, yeah. Um, in the time we have left, I want to talk about MDMA. Getting a lot of attention right now, given the recommendations that were just released to the FDA ahead of the FDA actually making some big decisions coming up here. Um, I don't know. I'm assuming you followed this at least somewhat. Can you just tell everyone what's going on right now with Lykos Therapeutics and MDMA-assisted psychotherapy in terms of whether or not it's going to be FDA approved?
Sure. I have been following it very closely. And I was a early, I don't want to say early adopter, that's the wrong word, but I was very excited about MAPS, which is since split into Lycos, from a pretty early age. I was like in college. I came out to California after college to work on the only MDMA study in the US that was ongoing at the time. I got $500 from Rick Doblin in 1999 for, reviewing ancient papers giving MDMA to pigeons and rats, as part of the, IND filing. And that was supervised by an actual scientist, Matt Baggett at the time. But anyway, so I've been, fascinated by this. And the thing that caught my attention very early on through personal experience, to be honest, is the transformation, like like life-changing experience. How could this not be good for something, right? And when when I heard for the first time in the mid 2000s that they want to explore this for PTSD, like it makes sense. Like these memories that are so painful, awkward, humiliating, et cetera. Like you can deal with them, you can process them, you can move on. Um, that's that to me was what was so compelling about this. Now, what's happened in the interim is, what does it take to get MDMA, a drug that's been illegal since the mid '80s, and Schedule One? How do you make that into medicine? It takes some evangelism, and that Maps and Rick Doblin, who I know and love, but he is an evangelist. He's that at the heart of it, and he believes in the stuff. And it's not the kind of attitude that really lends itself to carefully controlled, agnostic, equipoise in a clinical trial, which is what you need to get this over the hump into a medicine, into something that insurers are going to pay for. A doctor can say, this is going to help you. Here are the studies to back it up, regardless of whatever societal hype there is around. So this to me was the basic challenge that they're, they it's not a pharmaceutical company in the conventional sense, and they didn't present the FDA with, clinical trials that look like other phase 3 clinical trials. The MAPS MDMA-assisted psychotherapy for PTSD application, to my knowledge, includes 2 clinical trials. They're pretty small by most standards, about 80 patients each. For reference, the Compass psilocybin trial, phase 2b, have like 250 patients in it. Like that's typically drugs are approved with thousands of patients in trials. So this is not a big trial. And they did, they got breakthrough status in 2017 or 2018, meaning that the FDA would work with MAPS on designing the trials and getting them right so that they would be approvable, pending the results once they came before the FDA. So what happened in the last couple of months is that some independent bodies and the FDA advisory committee started reviewing the data. And what came out at this hearing, which happened earlier this month, which was this very widely publicized 11-1, no confidence vote in MDMA, was basically the revelation of just a number, like a dozen, maybe more issues with the way the trials were done, with the measures they used, with the design, with deviations from what the FDA had recommended, which I don't fully understand why some of those choices were made. If the FDA is giving you a checklist of things to do to get your drug approved, like I would do every single one of them to the absolute best of my ability. It did anyway. So some of it was mystifying, but so what happened? The long story short is that MDMA, two very successful clinical trials were published in very high profile papers where folks who had not gotten better from anything with severe PTSD were getting, in remission, lots of patients. Cover of the New York Times, right? Like really big news that this could work. And, I'll be honest, like it played into my own biases that, yeah, like of course it worked. Like that's what I thought would happen. But you need to do these trials, you need to have some equipoise. You need to not already assume the results before you get it in hand. So that despite all of that, excitement about the clinical trial result, when the details and more importantly, some of the allegations about misconduct in the trials, that really, I think, sunk the application.
What were the allegations?
So one of them is not just an allegation, but just a finding of fact that there was a sexual assault in one of the phase 2 trials in Canada by an unlicensed therapist. That happened. And that, could have been handled more transparently, I think, by MAPS, but it doesn't really inspire confidence, in the process. Again, this is assault. Like you can't blame assault on MDMA. It's like this is like people who do the assault, like that's who you should be blaming primarily. But it raises questions that, well, are patients going to be, hyper suggestible to this kind of thing? And I don't think we have an answer to that. So, that's I'm not really saying one way or another, but we just certainly it raises a question that we don't, yet really fully understand. What is the risk? Is that something, do we disclose that to patients, before giving them MDMA? Like it raises questions like that. Mm-hmm. There are other, unsubstantiated allegations, at least unsubstantiated in my view, that, there were like patients were, very much pressured to give certain answers to questions, that they would be excommunicated from, very much an in-group community if they said anything other than, MDMA saved my life. I don't know if that's, again, this is like
those are allegations.
It doesn't inspire confidence.
Yeah. As a scientist, when you look at those phase 3 trial results, those studies, do you think the results are compelling? Even if, traditionally you'd want those trials to have more patients, do you think there's any serious pitfalls in how the trials were conducted?
Can you repeat that question? I blinked out for a sec.
Oh, how compelling do you find those studies, the phase 3 clinical trial studies?
I mean, I thought they were pretty compelling, to be honest. Assuming that assuming the patients were free to answer as they wanted. There are, of course, there are issues with it. Of course, it's not, a blinded study, which you can't do really for this kind of drug. And honestly, you look back at all of the drugs that have been approved for mental health indications. We have the assumption actually should be that none of them are blind. So I don't think that's as big an issue as has been made out. I think what would have been nice, this is what they could have done better. And of course, this is Monday morning quarterbacking. There are two big ways to address the placebo problem, right? It's like, so right, like the default criticism is, well, it's all placebo effect, which, even though you don't really see that degree of placebo effect in patients with severe PTSD, okay. The one thing to do is a dose ranging study, right? You just if there's a dose dependent effect, you should see, right? If it depends on the drug, you should see an escalating effect with increasing drug dose. Also, not totally blind, but it addresses some of the issue. That would have been a nice thing to do. The other thing that I think they really whiffed on is the long-term follow-up, right? I don't know a placebo effect that lasts a year, right?
Yeah.
So, whatever, there's the hype, of the study, and like there's an experience associated with it. A lot of that stuff, you'd expect to wear off and people go back to their normal lives and eventually they settle back to where they were. Right now, if you dealt with some trauma in a very real and lasting way, you could follow those patients out and still see improvements. And that would speak volumes, I think, to the fact that this is a drug or a treatment specific effect, not just placebo. Unfortunately, the data that they collected on that was not really interpretable, and the patients knew what group they were in, or they were told. There are some placebo patients who thought they got MDMA. So there could have been, with enough numbers and enough follow up, and of course they lost a lot of patients to follow up. So what happened to the ones they didn't follow up with? All of these questions, like it wasn't a really high quality long-term follow-up study. So those were, the big issues.
So do you think, I guess my intuition here would be the FDA probably says we want to see more data.
Yeah. So, whatever the sins of Lykos were, are, I don't know, we still have an intractable public health issue for which there are very few effective treatments. And, the FDA is, they're judging safety and efficacy. But there's one of the safety and one of the risks that I think is a real risk is that by saying no to this, you are also stifling development of other drugs. And that is, I'm purely speculating here, but I think that may have been involved, for example, in, why did the FDA approve an Alzheimer's drug that was subsequently pulled for lack of efficacy and safety? Is because nothing had been approved for Alzheimer's in decades. And, at some point you're going to stop taking shots at that. Esketamine, the trial data for esketamine, not that impressive, but the FDA approved it. And again, to me, it was a strong signal to the industry, guys, like, please, like, this is
keep working on it.
Approach. Keep working on it.
Yeah.
So that's sociology, not science. And I think thankful I don't have to, make that decision on the FDA. But so I think there's a possibility that they will still approve it on that basis, saying, they'll have a really restrictive REMS, which is the risk evaluation mitigation strategy, that will, really kind of tie up who can get MDMA, how many times they can get it, who gives it to them, really make it difficult, make it expensive, which, none of that is great for patient access. But it will allow, leave the door open to give more data, to, change the label. And it gives a signal to other startups, of which there are many, that, hey, there's at least a possibility here, that we're not closed off to the possibility that you could have a drug that really primarily works in the context of psychotherapy. It's approvable. It's not the kind of thing they're used to approving, but there's precedent for drugs that have abuse liability. In the height of the opioid epidemic, the FDA approved, a new formulation of an incredibly potent opioid that's, 10 times more potent than fentanyl. So there's precedent for that. There's precedent for the FDA approving drugs that require some sort of psychological support. Buprenorphine for opioid use disorder, bupropion and Chantix for smoking cessation. These these are approved with the proviso that you're in some sort of ongoing support. So these are MDMA is, I think, approvable given the right given the right shape and quantity of clinical data. I don't know if I don't know if that's enough to make the FDA overrule an 11-1.
Yeah, we'll see. Towards the end of the day on a Friday, I don't want to take too much more of your time, Boris. I know that you're busy. Is there anything that you want to reiterate about what we discussed today, or any final thoughts you want to leave people with on these general subjects, psychedelics, anesthesia, consciousness, the role of subjectivity, any of that stuff?
Yeah, I think I really want to reiterate that point about, experience and not falling for a trap that, I feel like I've fallen into many times, which is this like reductionist mechanistic, illusion that we can boil things down to something as simple as a shiny pill, that's going to hit this receptor and like turn on the lights. It's so, that can happen, but I don't think that's how this stuff is working. And I think chasing that as a strategy is really not going in the right direction. I think experience, transformative experience, ritual, expectation, the build up, the all of these things, like that seems to be the common through line through all of these drugs, that there's something important about generating those types of experience. And they're done, just look at the pharmacology of ketamine, MDMA, psilocybin, not really that similar, but they all seem to have this, yes, they're psychoactive, they have durable effects. And these are potent therapeutics. To me, it really seems to center around transformative experiences.
Mm-hmm. Yeah. And I guess like one final thing I want to say, as I'm hearing you say all these things, and when we had our discussion about some of this stuff, when you think about this historically and anthropologically, all of the things that are the most transformative for people in society center around rituals where you feel special. Think about a marriage ritual or a rite of passage, becoming a man or a woman. All of the ceremonies that cultures all over the world have always used involve all of the ingredients minus the drugs that we seem to be talking about here.
Sometimes with the drugs, but
sometimes with the drugs too.
Yeah, that's, I think we can go too far in that direction. That is medicine really the home for transformative experience? Maybe not. But it's taken over so much of our lives, and it's an important lesson that I think is what we should be taking away from these trials and this movement. And it's not the lesson that everyone is taking away. I think the lesson, that there's a lot of excitement about derivatives and analogues and re-engineering the compounds, and maybe less excitement because it's hard to generate intellectual property around an experience. But to me, that's the frontier, is really trying to engineer experiences in a thoughtful and somewhat predictable way to affect change.
All right, Dr. Boris Heifets, thank you for your time.
Thank you, Nick.
This episode is supported in part by Athletic Greens. Their main product, AG1, is a comprehensive and convenient daily nutrition product containing 75 vitamins, minerals, and whole food sourced ingredients with less than 1 gram of sugar per serving, no nasty chemicals or artificial anything. It's gluten and dairy free and compatible with paleo, vegan, vegetarian, and ketogenic diets. AG1 is a quick and convenient way to supplement your diet to help ensure your body is getting the nutrients it needs. It comes in powder form, and you can mix it in water and drink it, or you can put it into a smoothie or a shake or something like that. I mix it into water and drink it, and it's super convenient. If you go to athleticgreens.com/mindandmatter, Athletic Greens will give you a free 1-year supply of vitamin D and 5 free travel packs with your first purchase. Their vitamin D product comes in tincture form, so you just take 1 drop each day. A large fraction of the population is actually vitamin D deficient, especially in winter months when we get less sun exposure. And vitamin D is super important for the proper function of the immune system and for a variety of other things. So visit athleticgreens.com/mindandmatter or click the link in the episode description. You'll get a free 1-year supply of vitamin D with your first purchase.